today I'm going to present a case history of peritonitis with sepsis. My patient named Wong Yong Kong, 21 years old, coming to hospital with pain in the iliac region, started 2 days ago. Additional complaints are nausea, headache, malaise, fever up to 38.9 degrees Celsius, watery vomitus, loss of appetite, weight loss, thirsty, and oliguria. In objective examination, my patient is having acute abdomen caused by infection. There's sign of intoxication and non-hemorrhagic dehydration. Respiratory system is compromised with increasing of respiratory rate, muscle retraction, and then there's a level of forward rate on the right lung, showings of displacements of lower border of the right lung upward. Cardiovascular and peripheral vascular is also compromised with hypoperfusion and also tachycardia. And radial pulse is weak and fast. GIT is compromised with GIT dysfunction and also paralytic ileus. Genital urinary system is compromised with extremely less urine output with abnormal conditions of urine. So my primary diagnosis is acute abdomen, non-hemorrhagic dehydration, and severe sepsis. Obtain of laboratory and instrumental diagnosis. Complete blood count, white blood cells is increased, band cells is high, neutrophil is high, ESR is increased. Blood chemical analysis, carbon dioxide is low, total protein is high, albumin globulin ratio is high, AST is high, and also C-reactive protein is high, lactate level is also high. During the urine analysis, there's a brownish color of urine, turbid clarity, specific gravity is high, and presence of protein in the urine, which is proteinuria. And microbiological examination, there's detections of microorganism, which is E. coli. In the instrumental diagnosis, in the plain chest X-ray, there's fluid accumulation in the pleural in the right lung, levels in the fourth rib. There's fluid accumulation in the pericardium, hydropericardium, and there's infected fluid in the abdomen, shows a rainbow-like shape in the lung region, which is peritonitis. In the abdominal X-ray, there's dilated bowel loops observed, which indicates acute appendicitis. In the ultrasound, we also detect infected free fluid in the abdomen. So my final diagnosis, the patient is having peritonitis, severe sepsis, and coexisting disease is appendicitis, second-degree non-hemorrhagic dehydration. So I'm giving my patient a fast IV solution, which my patient is having septic shock. So at the morning of 10 a.m. until 12 p.m. I'm giving 2 liters of IV solution, which is natural saline 1 liter and dextro 5% solution 1 liter. Until 12 p.m. patient's vital sign is slightly normalized, and the patient is admitted into emergency department in the ground floor, bed number 5. Time is 10:30 a.m. in the morning, together with IV solution. Medical treatment, my patient is having supine position. Diet is NPO, gastric lavage, yes, as a preoperative emptying. Antibiotic is ceftriaxone, intravenous with metronidazole. Cubital access with IV cannula, normal saline plus dexo 5% solution, we put it just now. NSAIDs, I'm giving ibuprofen, intravenous, 10 mg per liter once daily. Diuretics, I'm giving furosemide, 40 milliliter, Prios, and local anesthesia for thoracentesis because my patient is having hydrothorax with the lidocaine 0.25 transdermal, and pericardiocentesis in the fifth intercostal space at the left sternal border at the cardiac notch of the left lung for aspirations of fluid in the pericardium. For thoracentesis in the sitting position on the posterior right 8 intercostal space, anticoagulant heparin is given and folic catheter is given. After pericardiocentesis and thoracentesis, plain chest X-ray is also done to confirm that the fluid in the pleural cavity and pericardium is removed. Surgery treatment, yes, is emergency surgery, and we are giving laparotomy and appendectomy. Day of the surgery in the same day, 12 p.m. Type of surgery is emergency. Indicate, yes, indication is life-saving. Planned surgery is laparotomy and appendectomy. Analgesia is general anesthesia. Artificial ventilation is yes. The risk of surgery is high. The risk of thromboembolic complication is moderate. Bleeding is moderate. Contraindication is no. The chances without surgery to success is 0%. With the surgery, chances to success at 80%. Consent and preoperative checklist is done. Patient is having vital sign, body temperature 38.2 degrees Celsius, pulse 95, heart respiratory rate 24 breath per minute, blood pressure 110 and 85 mm per mercury before the operative checklist in the time 11 to 11:30. After that, the surgery is done at 12 a.m. Scrubbing, grounding, gloving, prepping, wrapping is done by scrub nurse and surgeons. The surgical access is at the right mid-clavicular line, laparectomy. Remove the fluid from the pericardium, find the source of peritonitis, which is appendicitis, and done appendectomy. Clean the abdomen cavity, put abdomen drainage, open drainage, and close the abdomen. Intraoperative anesthesia report is together with intraoperative monitoring with monitoring of blood pressure, respiratory rate, pulse pressure, temperature, and oxygen level. 1:30 the surgery is done. So the patient's vital sign is maintained within a range and he's getting better. Post-operative care day 1, the patient is in the ICU until 2 p.m. and then change to dressing ward, and after that change to normal ward. Patient is having malaise and weakness. The patient's skin and mucous membrane turns from dry to moist. Turgor is normal. Armpit and tongue are moist. Muscular system. Patient is still having decreasing in muscle tension and strength, and it is expected. The bones and joint, there is no pain when moving. Nasal wing do not participate in respiration. Lips is in normal color and moisture of lips. Conclusion, the signs of non-hemorrhagic dehydration is absent. Tachypnea is absent. Painless, the patient is getting better after the surgery. Respiratory system, cardiovascular system, GIT system and genitourinary system is getting better. Vital signs are maintained in the first day. The wound drainage, there's 70 milliliters in the first day. And then the urine observations, they are getting normal. We are giving patient compression stocking to prevent thromboembolism. Antibiotic, analgesia and anticoagulant is also given. We also give 2.5 liter of IV infusion to maintain the solution in the patient. After the first day, lab and instrumental test is done. So in the laboratory result, there's still signs of infection, but it's expected, and as we are giving antibiotic and it takes some time to recover, and there's no electrolyte imbalance shown. In the urine analysis, everything is going back into normal. The patient does not have non-hemorrhagic dehydration and he's getting better. Day 2, in the subjective examination, general inspection, respiratory system, cardiovascular system, GIT system and genitourinary system, the patient is getting better. The condition is good. There's no signs of hemorrhage in the site of surgery and the patient is getting better. Vital signs is slowly going back to normal. We are still giving antibiotics and NSAIDs for the second day, and patient vital signs are normal and patient is getting better. Day 3, there's no more complaint. Patient's objective examinations is all good. The vital signs are normal. The patient's condition is getting better as we are still giving antibiotics, as the period of antibiotic is 1 week. The laboratory report, all the tests, they are going back into normal range. So in the plain chest x-ray, there's no signs of pathology in the plain chest x-ray. There's no hydrothorax, there's no hydropericardium. In the abdomen x-ray, there's no free fluid in the abdomen. ECG, everything is normal. So laboratory and instrumental tests gradually normalized. Plain chest x-ray and abdominal x-ray show no pathologies. ECG shows normal pattern. The patient's vital signs are gradually back into normal state, which indicates the surgery and medications is working well. Antibiotics are prescribed in a tablet form to avoid antibiotic resistance, and patient is discharged. That's all for my presentation. Thank you.